Good afternoon to everybody signing in to our first Voice of the Expert session for this year. It has taken us a long time to get our hands on Dr. Reid. I've met Dr. Reid a couple of times, and she's a specialist physician, originally from KwaZulu-Natal. And she's actually an internal medicine fellow at the University of Cape Town. And she's a fellow in the Department of Rheumatology. And we've met a couple of times before, and she was very happy to put her hand up. I said to her that we wanted to talk about blood today. And that is a question we often get from our patients is how does it all work? And we're looking forward to taking a little bit more of a deep dive into this with you, Doctor, today. So I think before we get into all the nitty-gritty, gooey, bloody details, I just wanted to, ask a bit about yourself and what is the role of a rheumatology fellow? What does the role fellow mean? So that patients that are listening can understand this.
All right. Hi, and thanks for having me today. So to be a fellow in rheumatology really means I'm doing a subspecialty training in rheumatology. So I've trained as a specialist physician in internal medicine, as you said, and this is really just focusing specifically on rheumatology. So it's a 2-year program where we hone in and we really get our clinical skills, and in the end, we write a series of exams and become formally a rheumatologist. So that's what I'm doing. I kind of found my way here when I was training in internal medicine in Joburg, and we often had a lot of young patients with quite severe manifestations of autoimmune disease there. And then, although they kind of one might think of them as quite rare, we see them fairly often in internal medicine, and I noticed that they affect a lot of young South Africans in many different ways, and they have a profound impact on their lives.
Mm.
Patients who often are really in the prime of their life, they have young families, they have a lot of pain and disability, but you can make a big difference in their lives if you detect and diagnose their conditions early and put them on appropriate treatment. And I felt quite inspired by how rheumatology is quite comprehensive, it's multi-system, it's holistic, and you need that to really deal with the complexity of autoimmune disease. So that's why I ended up in this, and I will be here for 2 years at Groote training in rheumatology, essentially.
Oh, that's a beautiful story. And the word complex certainly comes to mind when one thinks about autoimmune diseases. I mean, I think our expert patients would definitely agree with that statement. And I can hear that this is a calling. I mean, there's a lot of specialties to choose from, and that you chose this one is
Mm.
remarkable. And we would be, once you get on board, South Africa needs rheumatologists. So, I mean, I'm actually interested to ask you, what does a fellow actually like do every day? Like, what does a typical day look like for you?
So we work with the kind of consultant rheumatologists who are here. We see patients by ourselves, alone, together with them. Usually we have a clinic every day, and we run very busy clinics, new patient clinics. We do follow-up clinics. We see patients in the ward who are very sick and admitted, and we see them both with a new disease and established autoimmune conditions. And then we just train essentially in clinical practice. We assess patients, work on our diagnostic skills, and then treatment options of various different autoimmune diseases, including axial SpA. So it's a variety of things we see. A lot of our work is with outpatients, but we also see a fair amount of inpatients as well.
That sounds like it's almost like a bit of detective work, right? Because the autoimmune disease doesn't always present, as easily as one thinks. I'm interested to know. I know you see a lot of uh, patients from all the different R&D diseases, but how often do you come across axSpA patients in your clinic?
Yeah, so as you say, it isn't the most common condition we see in our practice, but we definitely see it every week or two. I would say I see someone with axpa, but so we see them regularly, and then we like I said, we see new patients. We have a new patient clinic once a week, and I would say once or twice a month we see a new patient with axial spa. So it's and then on our follow-up clinics we see them every week or two essentially.
Mm. No,
Mm.
Axpa is definitely not the rock star of the stage in terms of, if you think about RA or gout or any of the other diseases.
Mm.
That's wonderful. It's also quite interesting to see what happens behind the scenes, because obviously we always see the rheumatologist, then they've already gone through the whole
Mm.
process that you're walking. So it's lovely to hear, how specialized it is, that you don't just become a rheumatologist, that you really have to like drill down into those details, as you said. Um,
Mm.
so, I mean, the reason we're here today is to talk about blood tests, and
Mm.
that's a question we get so often. When an export patient walks into a room of a rheumatologist, that I mean, the first thing that we get told, well, obviously, if you're a repeat client, you'd almost do your test before you see the doctor. But if you're a new client or a patient, sorry, I'm thinking I'm at work, but I'm actually talking about patients. If it's a new patient, then immediately the doctor will start filling in all those forms. And I mean, that's where we all start getting very confused, trying to understand, the whys and the whats, and why that really is a starting point.
Mm. Yeah, so what we start off with, I would say that there's no standard panel or blood test that we use to diagnose axial SpA. We order tests depending on the patient's clinical profile, and we make a diagnosis that is predominantly clinical, and the laboratory tests and the imaging help put it all together. Um, so, it's like pieces of a puzzle, and each piece is a different component. The blood tests are a component of the puzzle, and we have to then step back and look at the whole thing to make a clear diagnosis on a patient. So, if I could talk you through some of the tests that are often done, um, I've got a sort of a few that we often encounter and patients want to discuss. So there's this test called HLA-B27, and that's a blood test, and that's really for a gene associated with axial SpA, and it's used to help in the diagnosis, but it's not used in every patient. So essentially, what is HLA-B27? This is a protein on the surface of white blood cells. It's associated with a group of autoimmune diseases, so not just axial SpA, but a group of diseases called spondyloarthritis. And this may include reactive arthritis or psoriatic arthritis. And typically we'll test that just once at the beginning of the patient's diagnosis. But I'll get into it a little bit later, the details and the nitty-gritties of it. But you can also diagnose axial SpA without that test. So you don't need it, but it is sometimes used as one of the puzzle pieces in patients. Then we have other tests that we use, such as ESR and CRP, and we'll get into those details just now. But these are markers of inflammation, and they're used as part of an assessment of a patient with any autoimmune condition or inflammatory condition. So other patients with rheumatoid arthritis, etc. Sometimes we might have done an ESR or lupus, and we use them in combination with the clinical information, such as the history and the examination findings, X-rays and other imaging together. So we can use it as part of the diagnosis of axial SpA, as well as for monitoring the patient's condition. In particular, our CRP is used as part of our ASDAS tool, which helps us to see how the patient respond to treatment and how their disease is progressing. We often do a full blood count, and that really counts the number of white cells, red cells, and platelets in the body. And these we measure quite regularly. It's part of the overall assessment of the patient, and they can show different things like anemia, low blood counts, inflammation, and many different diseases as well as medications can affect different blood counts. So we monitor those quite regularly during treatment. And then we also often monitor the liver and kidney function as part of the overall assessment of a patient. They can be affected by many different conditions. and many of the medications that we give patients can affect those. So those are some of the common blood tests that we would do when a patient comes in. But like I said, we use it in conjunction with the history from the patient, the clinical examination, maybe laboratory tests then, and then we look at doing other investigations such as CT scans, X-rays, MRIs, etc.
Mm. So am I understanding correctly? Obviously, with your initial, before you make the diagnosis, there's a lot of tests that gets run. And then obviously once you're diagnosed and you become a returning patient, then there are maybe more standard tests that gets
Mm.
run on
Mm.
repeat. Because you
Yes.
wouldn't, for instance, do an HLA B27 every time because once you're positive, that would not change.
Yes, and equally, if you're negative, you're not going to change to be positive. It's a genetic test, so it's done once off at the beginning.
Mm.
So is your question about which tests we use to do, which ones we do monitoring on? So
Yes.
typically, the ones we would do monitoring on, some patients might need repeat kidney tests or liver function tests if we are particularly on medications that affect that. And not all of the medications would do that. So we might repeat your liver tests and your kidney tests with regularity, but we would definitely monitor the full blood count. That's really important for us. And then we'll often monitor patients with a CRP. That's our C-reactive protein, and that's one of our inflammatory markers that we use as part of the tools for monitoring. So those are our typical monitoring tools. And then there's a few other tests that we do right at the beginning of diagnosis just to stratify the risk and look for infections, such as HIV testing, hepatitis B testing, hepatitis C testing, and we might do TB testing on the blood, or there's other ways of testing for TB. So those are the ones, that we do at the beginning, and then later on we usually monitor the blood counts, the CRP, and we might, in selected patients, keep monitoring very carefully their kidney or their liver function if we're concerned about that.
Mm. So if you can, if we can stop just at CRP, because that's one we hear a lot of. I mean, HLA-B is at the beginning. If you can just maybe break down in simple terms to us what CRP even means.
Sure.
And that you were talking about red blood cells and white blood cells, maybe just in very layman's terms, why you would be looking at that and where does inflammation come into that? Because I mean, that's what we all have inside our bodies, right?
Yes. So white blood cells are also raised in states of inflammation. And red cells are really, that kind of gives you an idea of anemia. And those can be affected by quite a few different things. So anemia, you can get it from many different causes. But when you're looking at infection or inflammation, and you often see patients with high inflammation markers, you might see an elevated white cell count. Now, the CRP is a kind of protein that rises during inflammation. It means C-reactive protein. And it's a protein in our body that increases from inflammation, but it can be from many different things. So, they can be infections such as urinary tract infections, pneumonia. It can be raised in patients with other inflammatory diseases and flu-like illnesses. So CRP can be raised from various different things, but we use it in a composite manner. So we put it together with the history from the patient, how they're feeling, how their pain is going, and we use it as one of the tools in the kind of toolbox of when we're looking at a patient on the day and seeing how they're doing. Something to note about the CRP is that some patients will have active disease, but they don't have a raised CRP. So having a CRP that is normal, it doesn't mean that your disease is inactive. But having a raised CRP for us when we're looking at the patient might mean, for instance, they're more likely to respond to certain medications. So sometimes patients might say, well, I have a lot of pain, but my CRP is normal. What is going on? And it can be a few things. You might have inflammation, but a normal CRP, we definitely see that. But the pain could also be caused by other things, and it may not be related to active axial SpA. So the pain can be due to other things like osteoarthritis, fibromyalgia, degenerative spinal disease, spinal fractures, if we're talking about back pain. So we really need to look at the patient holistically and see, is there anything else causing the pain? So we use the CRP as part of our assessment, but it's not the be all and end all, because we do know that some patients can have active inflammation but a normal CRP, or have pain but a normal CRP, and other patients have a high CRP, and really it helps us predict who's going to respond a bit better to biologics.
100%. And now there's all these codes. It's CRP and then ESR. Can you maybe break that down a little bit simpler for me? These code words you have.
Sure. So ESR means the erythrocyte sedimentation rate, which is a long word to say how fast do the red blood cells, so that's erythrocyte means red blood cells, settle in a tube over time. So if they settle quickly and they all come down very fast, it's probably due to inflammatory proteins. And it indicates that there's a higher degree of inflammation in the body. Like I said, many different things can cause inflammation, and the ESR is, when it's elevated, it's quite a non-specific test. So we use it as part of the puzzle, but it doesn't necessarily mean that it's the inflammation is from axial SpA. It could be from that or from something else. So it's an inflammatory marker, but it's fairly non-specific.
That makes a lot of sense.
And just last thing on ESR is that it can go up from quite a few different things as well. So even benign conditions like pregnancy, obesity, flu-like illness, even increasing age can increase your ESR. So when people see an ESR that's elevated, it doesn't necessarily mean there's a reason to panic per se.
Absolutely. And I mean, you spoke about the full blood count, and then you spoke about liver and kidney function. Maybe we could just stop slightly there at the liver and kidney, particularly why are we looking at that? I mean, that was my first question. Why is the doctor looking at my liver and my kidneys?
So usually we do it at baseline, and we do it often because we give medication that are metabolized and processed and broken down in the liver and the kidneys, and then they are excreted out your body through your kidneys, a lot of the medication and some of it through the liver. So we need to know if your liver and kidney are healthy at the beginning of the disease process and are likely to process the medication appropriately, or if there's any problems with them, then we would investigate that. And then equally, we would like from time to time, or in certain patients, we will monitor the kidney and liver function very carefully, because we want to make sure that the medication isn't having any side effects where they affect the kidney or the liver. So non-steroidals are known to have an impact on the kidney function, and you wouldn't want to give those medications to patients with problems with the kidney. And you'd want to be very cautious if patients have liver disease about certain medications. So it influences the treatment that we give a patient.
Absolutely. So, I mean, from what I understand is that the blood tests can help you with diagnosis, but it's not the only, it's one of the tools it's almost like pieces of puzzle you put together before the diagnosis. And then after the diagnosis, these blood tests, you'd obviously have a baseline, and every time you do these blood tests, you will have a baseline to work against,
Yes, that's correct.
monitoring the patient.
No, that's right. And we tend to repeat blood tests over time, particularly when we're monitoring the patient, for two reasons. Number one is to track the disease activity and to adjust our treatment towards basically the goal of remission. And we know that patients with autoimmune diseases, they fluctuate in intensity, and they have periods where they're active and they have flares, and then they have quiet periods. And we really use these tests to help us monitor that disease activity. And then the second one is to monitor for any medication toxicity. So if it starts to affect your blood counts, or if it starts to affect your kidney function or your liver function. And that's really because some of the medication that we use is quite powerful, and they can be powerful immunosuppressants, but they can also have a series of side effects that we want to detect early and treat if needed.
Absolutely. And because a lot of us need to take the medication over a long period of time, right? It's not like just use it for 2 or 3 weeks.
Mm.
I just want to briefly stop at the word remission.
Mm.
That's always a very interesting word, and that's a question we get, well, remission, is it possible? And then how long can remission last forever? Does remission come and go? What is remission? How do you use the word this and this happens, then it's kind of what remission looks like? Or how do we get to the word remission? Because I guess that's the closest word we're going to get to a good picture, right?
Yeah, so in most of these autoimmune diseases, and axial SpA as well, they don't go away and we say that the patient is cured. We don't say that the patient is now totally free of disease. But remission is a word that we use to say that the disease is quiet, that there is activity, the disease activity is very, very low. The patient has a very low level. When we do our scores and we use, for instance, our ASDAS tool, we look at a very low score, which for the patients would mean that their pain is very well controlled, that they have good function, that they
Mm,
don't have any significant stiffness or back pain, and that they really feel as well as they are able to feel. And some patients may feel as though they are totally better, as though the disease is gone. But
mm.
we don't say that the disease is gone. We say that they are in remission, that the disease is quiet, essentially, that it's well treated, that it's under control.
Absolutely. And so one of the questions we get a lot is why do we repeat these blood tests? You've like go to the rheumatologist and the first time you get diagnosed, you get all the tests done, and then obviously these tests repeat themselves. And I think we might have already asked it that you can keep a eye on the patient and how they're faring. Um, but what are you watching for from the first time you've seen us to the second time you've seen us? And is there different tests that you would do? Let's say a stable patient that's you see is really doing well,
Mhm.
and a patient that is maybe not doing well. Does their blood tests look different?
So in a patient, we tend to repeat them, like we said before, for patients to monitor their disease activity and then to monitor for any treatment toxicity or side effects. So any particular stress or damage to your liver, kidneys, to the blood counts, the bone marrow. Um, and we for instance, if we have recently changed treatment, if a patient is unwell or their disease is very active, we might do blood tests more frequently. So we'll do it like between maybe every 1 to 3 months, depending on the patient. And usually that's because we're changing or increasing doses of medication and we want to check if the patient is tolerating that well. And then in a patient who's stable, we would stretch those out to once every 6 to 12 months if they're very well and we know that they're on the same treatment, we haven't made any changes. But we would do a similar set of tests. So we would probably do a full blood count, a CRP. If we're concerned, we might do liver functions or kidney functions, depending on what changes we're making to the medication. So really, the thing that changes in a more unwell patient is we do them more frequently, or if we're making big changes to the medication. And then once the patient's more stable, we space those out over time. But we do need to keep monitoring them
Mm,
because it helps us get an idea of if the patient's tolerating them well, and how their disease activity is.
mm. And if there's anything that changes in these blood tests, whether it's, let's say your CP takes a big fly up the wall, it can't be your HL, but all those other markers, that's obviously when you as a specialist stop and I don't know, do you make changes? Do you maybe not? What
If
are the
someone's CRP went up very high.
Mm,
So Because the inflammatory markers can be caused by different things, we would need to assess the patient and see what's going on with them. Sometimes someone's CRP goes up because they get pneumonia and they admitted to hospital. Sometimes someone's CRP goes up significantly because they have a disease flare. Sometimes someone's CRP goes up for something totally unrelated. And so we need to put it in with the other puzzle pieces, which is the history. How is the patient doing? The examination, you need to look at the patient and see has something really changed on this patient. And then put in the lab results and say, okay, we're putting all these pieces together. What's happened here? So we really use them together with the other ones, and if there is a high inflammatory marker, we need to try and look and see what's causing that. It's not a diagnosis in itself, but it prompts us to look and see what's wrong with the patient.
No, that makes sense now. And I mean, it makes sense that one needs to repeat your blood test now that I understand, how complex, it is to treat a patient long term with certain of these medications.
Mm.
I think the other question that I have is, AXPAR is obviously about bones and bone health, and you did mention the word anemia in the
Mm.
previous conversation.
Mm.
And I wanted to talk about, vitamin D, blood
Mm.
health, anemia, why you check it, and is
Mm.
there links, between this long-term inflammation and low anemia? And
Mm.
what are your concerns in terms of the health of the bones of a patient, if we're talking osteoporosis? And how
Mm.
does the whole bone thing, because that's also a whole lot of puzzles, I guess, that you need to
Mm.
together to understand.
So the first thing to say is that each patient is different. There's not always a one size fits all, and your rheumatologist may decide to say, look, I think you need to do a vitamin D level or a calcium level on you, and decide whether it's indicated for you. And the reason they might be doing that is that osteoporosis is very common in patients with axial SpA. This is from chronic systemic inflammation, and really it puts people at a higher risk for thin bones, which we call osteopenia or osteoporosis, and then that puts patients at a risk of fractures. It can be vertebral fractures or other fractures of the bones. So that's why we are aware of it, and it tends to happen much younger. So typically when one thinks about osteoporosis, you think of people in their 60s and older, but actually long-term inflammation can essentially drive bone loss faster than it's being rebuilt. And this causes, I think they say about 1/3 of patients with axial SpA have bone density loss or osteoporosis. And this happens early in the disease before the traditional kind of osteoporosis age. And these risk factors that put you at higher risk for that would be the inflammation, the spinal stiffness, the fact that patients aren't able to exercise as normal, and then medications that we use. So a blood test doesn't diagnose osteoporosis. If you are having a vitamin D level or calcium level done on your bloods, it gives you an idea of bone health, but essentially you use other scores. You use something called a FRAX score. That's FRAX, and that can sort of stratify you whether you're high risk, medium risk, or low risk. And then you would use something called a DEXA scan to try and diagnose osteoporosis. But we do know that patients with axial SpA have a higher risk from the chronic disease, the fact that they are may have less capacity to exercise, and there's chronic inflammation. So it is something that we are aware of, and because the disease goes on for so long, and it often starts in very young patients. We look for it in younger patients. We don't wait until they're in their 60s and older to start screening for it. We start screening and treating earlier.
That makes absolute sense. And I think um, that question I have for you now is, I mean, normally what happens is your blood gets taken, the results get sent to a rheumatologist, and then when you get there, it's discussed. I mean, we always say a patient that's knowledgeable about their disease always have a better outcome because they actually have an understanding of how these things work. And like you've quite rightly said earlier, this shouldn't make you panic, that shouldn't make you panic. So a patient that's well informed obviously will know these answers. Um, but what are red flags that you could see on results typically before you see a patient that would make you concerned before you even see the patient, or does it not really get that extreme in AXPAR?
I think the thing is that patients, we need to see everything together. So we need to see the patient and the symptoms that they're having. We need to see the patient with the examination of the patient, and then the blood results are a component of that. So, you might get a laboratory report which makes you panic and would have lots of things highlighted on them, but not all the results that are highlighted need to be acted on immediately. So we might expect to find inflammatory markers that are elevated. So I would say, without seeing the blood results and having an immediate panic, one needs to take them into the context of the patient that you're seeing. And as a patient, to be discussing each one of those results with your rheumatologist in
Mm,
person. So if there's something in particular you're concerned about, each patient's risk profile is different. So perhaps once you are established with a rheumatologist, understanding which of your results you should be worried about and which ones you want to track more carefully, I think it can be a bit more of an individualized discussion with each patient, depending on their baseline risk factors, etc.
absolutely. And I mean, that's such an important point, that the patient should be involved in their disease. And I mean, I don't know about you, but my rheumatologist loves it when I arrive there with a whole lot of questions and I'm interested and I'm asking questions. And that is a good, healthy practice for any patient.
Definitely.
And,
Definitely.
and what do you think? How does a patient get the most out of understanding now their blood results? Should they keep, I mean, my best practice for myself is I have a little file where all my scans and my blood tests are.
Yes.
I just think it's good. I actually arrive with my file and
Yes.
I can talk together with the doctor and with my
Yes.
things. But what are
Yeah.
tools and helpful things that you can say what they should bring with them when they go? Should they make notes beforehand? I mean, what are good questions perhaps? And how can patients actually hold their own blood result test? That's a question we get a lot.
So I would say, there might be a lot happening in a consultation. So if you're thinking about your consultation coming up, perhaps you can write down a series of questions that you might have. There's lots of things to discuss, and you might find it difficult to remember all of the questions in the moment. So that helps you just prioritize before you're getting there. What are the most important issues you want to talk about, and kind of focuses the consultation. From our point of view as clinicians, we don't usually need a printed copy from the patients. We usually have online access both in the state sector and the private sector. But when you're attending a consultation with a new doctor or in a new province or with someone you haven't seen before, you could bring a copy of your own results. That would be really helpful. Um, all patients are entitled to a copy of their results. So doctors won't have a problem sharing them. But if you want your results and your doctor's not able to print them or get a copy for you, usually the laboratory services are happy to send them to you, or they'll be available online with an app or an online portal, or even if not online, you can go to the lab where your blood tests are done and they can give you a copy of both the new results and the old results. So they are your results and you are fully entitled to have access to them. And we want patients to be activated and to be empowered. And a lot of patients feel like keeping track of all their results and correlating them with symptoms and correlating with them how they're feeling at the time really helps them, empower them, and feel in control of their disease. So we would encourage that for sure.
Mm,
And to be able to feel like this is their disease that they are managing together.
mm. Absolutely, that makes complete sense. And It always amazes me. Like, let's say you're going to have a child, right? You would spend months, I don't know, I had that book called What's to Expect When You're Expecting, and you paging through baby results and you marking down the baby's weight and you know exactly how many nappies it had and how many bottles or whatever. But somehow when it comes to our own disease, and I think specifically with the Axpar patients, a lot of them have gone through a very long road before they get diagnosed. They lose almost their confidence to even speak up, and
Mm.
talk about it is that they're concerned about. And I always say to the patients, you have to, when you walk into a rheumatologist room, think about the things and really talk to your rheumatologist about it.
Yes, definitely.
I think one of the most difficult things that I'd like to see if we can discuss, and we don't need to if it's off sides for you. Um, I mean, a lot of our patients are medical aid and funded and financially in a position, obviously, to to pay for all these tests, and a lot of our patients are not so able to, or they end up in the public system. And I mean, these tests are expensive, even if you look at the MRI scans and all the scans and whatever. And we're not so lucky with the PMB disease, our patients. So I mean, are there any tests that they can say, well, these shouldn't be done, or should they speak to the doctor about it and not be embarrassed to say, what are the tests say to the doctor, this, I'm struggling with my finances. Can we just do the test that we absolutely need? I mean, is that something a patient can actually say to a specialist, or how does that
Yes.
work?
So look, I mean, so we've discussed that tests are used for diagnosis and then there are tests that are used for monitoring. So we would say on the whole, axial SPA is both a clinical and an imaging diagnosis, and the blood tests add to that picture. And that's both in the public and the private sector. What would be the minimum that you must do in both contexts would be quite similar: a full blood count, a C-reactive protein, inflammatory markers, kidney function, liver function. And then we would just make sure that the patient's safe for medication. So they should get HIV testing, hepatitis B and C testing as well, and then screening for TB. So that should be done whether you're in the public or the private sector, and they can be done in both. When you get to the nuances of HLA-B27 testing, we haven't really discussed that in depth at the moment. But not every patient needs testing to make a diagnosis, because actually, when you look at it in this context here, most patients in sub-Saharan Africa, especially those without European or Asian ancestry with axial SpA, will actually be HLA-B27 negative. This is a blood test. However, if it needs to be done to add to the diagnosis, it can be done in the state sector or in the private sector. So it's not necessary that patients must get some tests done there. It is also available in the state sector. But just to say that, if patients are struggling with cost and access in the private sector, there is always care in the public sector. It's obviously some can be a little bit longer to get an appointment, etc. But there are a lot of different referral pathways that patients can be referred to the public sector. And blood tests in particular, they're all available. If it feels like your sort of primary healthcare provider or your rheumatologist is just doing panel after panel after panel of bloods, I think it is important to discuss the necessity and utility of all those extensive blood tests and panels, as this is not a disease where the blood tests are going to give all the information. We do need to look at the patient clinically and holistically as well. So I think it's worth a conversation. And just to remember that that the state sector is here, and that many of the tests can be done in the state sector as well as in the private sector.
Absolutely. So I've skipped over the HLA-B question, and that's completely my oversight. So I'd like to stop at it. And I actually kept it for last because we had one or two when we announced in our newsletter that you were going to come and speak. There were one or two questions about the HLB, so I thought we would slide it in almost at the end. So I would like to stop and talk about HLA-B27. What does it even mean? You're talking
Mm.
about proteins. I mean, in simple terms,
So,
what is this gene all about?
sure. So HLA-B27, it's a test for a gene. This gene is the instructions that writes a protein called HLA-B27. That means human leukocyte antigen. So that basically means a protein on the surface of white blood cells. And this protein, the job of this protein is to help your body's immune system tell the difference between its own cells and foreign cells or harmful substances. These
Mm,
proteins, they're made by instructions from inherited genes from your parents. So
mm,
HLA-B27, it's found commonly in patients with autoimmune diseases like axial SpA, but also a few other conditions such as reactive arthritis and psoriatic arthritis. And we use it as part of the puzzle of making the diagnosis. So having a positive test can be helpful, but you can also have axial SpA with a negative test for HLA-B27. So
mm,
90% of people with HLA-B27 are completely healthy and they don't have axial SpA. So having a positive test doesn't mean that you're going to necessarily have the disease. 90% of people do not have anything wrong with them. But doing the test is part of the pieces that help we put together. Then when you look in Africa in particular, the prevalence, which really just means how common it is in a population of HLA-B27 is extremely low. It's much higher in European and Asian populations around the world. So the likelihood of someone, who's in Africa testing positive is less than 1%. And but we do still see axial SpA, but it's much less common. And when it occurs in these populations in sub-Saharan Africa, it actually occurs in people who are negative for HLA-B27, and they thought that there's potentially other genes that would be responsible and involved. So we can make the diagnosis based on a clinical assessment, a history, and perhaps MRI or X-ray findings. And we don't necessarily need the HLA-B27 to make the diagnosis, although we do sometimes use it as part of the puzzle because it can help in some patients if they do test positive. But having a negative test doesn't mean you don't have the disease. And equally, having a positive test doesn't necessarily mean you have the disease. You have to look at all the pieces all together.
mm. So meaning if the HLA-B27 is positive, you could be asymptomatic, meaning just normal.
You could be totally healthy and have nothing wrong. In fact,
And
many patients are 90% of patients with HLA-B27 are not going to
mm,
have it.
mm. So what is the link then between why is HLA-B27 connected then to AXPAR? Because you were explaining about the protein that sits on top of the cell that sends out the messages whether they're attacking a good or a bad thing. Makes this HLA-B, why is it connected then to our disease?
Well, so white cells are the ones that are responsible in your body for causing inflammation and causing for causing the symptoms eventually. And when they looked at the cohorts of patients who developed axial SpA, they found that, and this was originally work done in Europe and in Scandinavia, where there's a very high prevalence of HLA-B27. And they found that most patients with axial SpA were positive for HLA-B27. So that's how it kind of formed part of the diagnostic criteria.
Mm,
But it doesn't have to be there. And you have to also take the context into account,
mm,
in particular in the populations where we are based here in
mm.
South.
And this HLA-B, we spoke about what is the hereditary factor of the HLB? I mean, uh, if you yourself are HLB27 positive, I mean, can you expect your kids? It's a question we get a lot of kids. Are they going to carry the gene with them? And should you check them? Should you not check them? And that's a question we get quite often. And so maybe we can answer it two ways. If you're a patient with HLA-B27 and you've got active AXPAR, and now
Mm.
you're having kids,
Mm.
would this be something that you consider having tested, or should you not worry about it? Or what would you suggest? I know this is not a clinical answer for this, but
No,
What,
there
what,
is more a clinical answer than there is not. So
that's good.
I would say the first thing that you need to say is that look first and understand that HLA between seven, it is passed down in families. But most patients with an HLA between seven do not have active axial SPA. So passing the gene down doesn't necessarily mean you pass the disease down. And then the second thing to note is that we always start our diagnoses with clinical information. So you have to have a history of inflammatory back pain. So I would say to have an awareness of it and say that this might be something that might present. And that if your children then start to complain about back pain and significant stiffness and nocturnal pain and you know, having symptoms is really where we start all diagnoses. We don't like to start diagnoses with blood tests. We like to start them with a clinical history and a history of symptoms in young patients under the age of 45 who start to have significant back pain and stiffness. So that's what we would say is keep an eye out, but don't be overly anxious and testing in a context without any symptoms to guide you.
Sure, because I mean, you could have a kid that's got growing pains or they've hurt themselves on the rugby field, they've hurt their back. That doesn't mean any, so I think you got also just calm things down and look at it like you say, in the balance of things.
Yeah.
If it's
The whole
normal around
picture.
that age. Yeah. And what is in closing, what is the single most important thing that you wish that people, patients specifically with axpo understood about their blood tests?
So I would say, something that we encounter regularly is just that people often do blood tests when they're feeling sick, but they may not do them when they're well. So I would say, please do your blood tests even when you're feeling well. Monitoring is really important. We have to continue safely prescribing treatment, and monitoring your disease process as well as possible side effects is really important. It's particularly important in patients on biologic therapy, but all patients need to be monitored. And whether you feel well or whether you feel sick, we would like you to please do your blood tests because they really help us complete the picture. Because, I think I've explained a few times that blood tests are part of the puzzle that we put together, and the puzzle is not complete without them. So it helps us to make better choices and prescribe safely for our patients if they do their blood tests, whether they're feeling well or whether they're feeling sick.
Absolutely. And I think this is one of the most important questions of the day. And what what is the safest path for a patient if they're feeling concerned about something that they see on the lab report? Where should they go for that first answer?
Mm. So I would say you could either discuss it with your primary healthcare practitioner, whether that's your GP or someone at the day hospital or whoever your primary healthcare practitioner is. They'll have a full history from you, or with your rheumatologist when you see them next time. And they know your personal medical history. I think everyone wants to turn to Dr. Google to give them all the answers, and it often causes a lot of anxiety and panic in patients. But you have to put the blood tests into perspective with the rest of the clinical information, and you have to look at them over time. A single snapshot view of one abnormal result may not be particularly concerning when you take a whole patient context into account, or it might be very concerning, but it's not a one size fits all, and we do need to look at it with the patient's history and clinical picture in consideration.
Mm. Very glad you mentioned that because Dr. Google is such a dangerous place because they do not have the full picture of the patient. They do not have the years of data, the clinical tests, the physical tests, the blood tests. There's so much more to it than for a patient to look at one thing and then run away with it. My advice is to every patient is speak to your doctor, go back to your rheumatologist. Make a phone call, leave a message, send an email. I think those pathways are always safe pathways to go back to your doctor.
Absolutely.
Wow, I've learned so much today, and thank you for your patience and answering my questions in such a easy language for all of us to understand. And I'm sure to all of our patients that's going to be listening to this is going to be such a wonderful tool for them. And not just for them, for their loved ones that don't understand, to explain to their families why these tests are important and why they're going through all of this. It is so valuable. And we really appreciate your time and speaking to us today. It was wonderful getting some insights from you.
Thank you so much. I appreciate it.
And have a fantastic day, and we hope to see you soon.
Thank you. You too. Appreciate it. Keep well.
Thank you. And to all the listeners and everybody that's listening to this recording, this was a recording done by Asasa, Voice of the Expert, all about blood. And we hope to bring you more clinical resources in the near future. Thank you for listening.
Thank you.
Thank you.